This is a wonderful event, a second in series that are sponsored by CUNY, Columbia, and the City University of New York. Um, we're the second of the three panels. Um, I'm not sure how many of you were here last night, so I thought I would just very briefly give you a couple of remarks about the very fascinating discussion that we had last night and see if we can make a link between what was being discussed yesterday and what we may be discussing today. I want to try to give some brief remarks. Basically, last night, the way I saw it was that, whoa, let me see if I can get this down. Okay. Uh, about was really about the political economy of New York and what would happen after the pandemic faded, after we got past the pandemic. And the assumption was kind of two various scenarios, and I'm summarizing my take on it, so please bear with me. The two various scenarios were one, that we really faced a world of doom and gloom in which African American and Hispanic peoples bore the burden of disease, along with the more general economic disaster for the city as a whole. Well, on the whole, there was a belief that the city would face serious problems. Others in the discussion were more optimistic and emphasized that the unique political economic position of the city would in some sense protect it in the long run from the worst excesses of the pandemic's impact on our buying habits, our living habits, whether or not our stock market would recover, whether or not our housing market would recover, whether any of us would ever return to going into a store when we've learned and been trained to go and turn to Amazon for virtually all of our goods. What would happen to the economy was a question that underlied everything. In some sense, there was one underlying assumption. I think it was that this was a financial and economic crisis that was rooted in a biological crisis. And there was an assumption that the biological crisis would pass. But the question historically is, what if it didn't? What if we put our faith in technology to address disease events, which yesterday were seen to be addressed through vaccines, medicines, and machinery, but that in the future, when pandemics became more endemic, when they actually just kept happening because of the world that we've created of climate change and international trade, and in which we've created a true petri dish for disease, what if they became constant and continual? Here we're going to try to broaden the lens of this biological event by looking at three places in time and space, all focusing on the self-evident point that a pandemic is both a biological and a social event that has meaning only in relationship to the specifics of the societies and the places they affect. Today, we're going to start out by talking about South Asia and the response to the pandemic in the context of a kind of a neoliberal movements that are occurring within that sphere of the world. The United States, in which our unique history has in some sense limited our ability to even define what the problem is, given that we have such a state-based public health system, and one in which even evidence, even data is suspect because we depend so much on very diverse systems of data collection. And finally, New York more specifically, New York City, but specifically the prison population imprisoned in New York and the kind of crisis that's affecting them as we kind of mouth a rhetoric of concern about those who are in congregate living and those of us who are subject to all sorts of social injustices and the reality of how we're treating people. So we're going to start out with Kavita Sivaramakrishnan. We'll begin by focusing on South Asia. Kavita is the Associate Professor of Socio-Medical Sciences at Columbia University. She studied at St. Stephen's College in Delhi, Trinity College and University of Cambridge, and completed her PhD at the Center for Historical Studies in India. She's a global public health expert who's written recently a book that was published by Harvard University Press, As the World Changes, the Making of a Demographic Crisis. I'm going to start out by just posing a couple of questions to Kavita and let her take it from there. You're a historian of disease. You're looking at COVID in the context of South Asia. Can I ask you, how would you frame the crisis and recovery in the context of COVID-19 in South Asia, and especially as a historian of epidemics? And what are the old and new patterns of disparities in power that you see emerging in India and across the global South. If I could just ask you to kind of generally give us your overview of this issue, we'll discuss it. One thing I want to say to everyone is that after the presentations, we're going to open it up to the question and answer button on the bottom of your screen, so that you can ask a question, and we will try to get to the questions and have you participate rather than us just talking to each other. So if you could, ask the questions through the Q&A, we'll get to them immediately after all three of our speakers have spoken. Okay, Kavita.
Thanks. Thanks, David, and thank you to the organizers of these seminars for having me over. I want to respond to you, David, by starting on what I think is trying to give an overview of what I think are some of the themes that we've raised in this panel. And I want to focus particularly on the two terms that really are, that we're really focusing on, which is crisis and recovery. And when I think of talking about crisis and recovery and pandemics as a historian from South Asia, I have to be then kind of querulous and say, I don't think I can look through that lens of crisis and recovery. In a way, when you're thinking of pandemics in South Asia, when we're thinking of a range of pandemics that have one followed the other, I think we're talking about crisis and survival rather than recovery. So in a way, what we're thinking about is really that pandemics really tend to be seen and interpreted as endemic risks. That this is not really a binary between what is epidemic and endemic. And that for a range of very dispossessed populations, for populations that have been marginalized, especially in an age of neoliberalism, what you see in South Asia is a growing movement to populations that suddenly become visible at the time of a pandemic as being objects of suffering, as objects of objects of certain kinds of public health interventions and surveillance. But these are populations that have already been exposed to a range of risks that are intersectional between pathogens, between infectious diseases, and the kinds of ecological risks that they're exposed to constantly. So when I think of this, I think that perhaps the way we could look at it, and I want to suggest it to all the panelists, is that we don't think really of only the big elephants in the big pandemics, that the way we need to connect this is not only to think even of South Asia as being, it has this big plague pandemic between 1896 to 1930. Then people tend to say, okay, the next pandemic, and we're moving from crisis to recovery, is the influenza pandemic of 1917-18. And then we move to recurring pandemics, in the return of influenza in 57-58, its return again in 68-69. So, there's always this kind of pause, as if there's a state of some health and normalcy that's happening between pandemics. But the way I'm trying to look at it is to see pandemics, if we connect them to local outbreaks, we're seeing them really as being pervasive. And we need to get out of this vocabulary of what is seen as a kind of finite outbreak. And the sense of thinking about pandemics as a crisis, and that's the first term I really want to unpack for you and all the rest of the audience, is that if we think of pandemics simply as a kind of crisis, what we begin to think of is that we think of these events as being kind of out of normal catastrophes, that they're really one-off events, that they're episodic. But the reality is that they're not like that. They're not just events that are unanticipated. They're unanticipated because we've not looked out for them, because we've refused to see the suffering of a range of the population that's been invisible to us. And it also means, in a way, that if we think of pandemics simply as a kind of crisis, it means that we'll forget what happens and we'll respond in very in ways that are not substantial. I'm thinking of the arrival of influenza in Calcutta in 1918. It arrives at a time when the Public Health Commissioner in Calcutta says that this is really the healthiest of seasons in 1918. It looks as if all the battles in public health, the death rates are low, we've conquered malaria, perhaps the plague is not coming back again. But at the same time, there's this huge devastation of influenza all over India, but also in Calcutta. But what happens is that the archive and the memory of that pandemic is so brief. Immediately afterwards, it seems to be that sometimes if we think of it simply in an episodic way, we don't seem to have any lessons No lessons really that come up as political and economic lessons, because we see this as a kind of one-off catastrophic kind of episode. So I want us to try and think beyond this sense of this binary between what is a pathological state and what is seemingly a return to what's a normal state. And this creates several other problems. I'm thinking, for instance, of a recent union budget. If we are thinking of a recovery process, and I know that Merlin and I were talking about budgets and thinking of what do policymakers do. So a good example recently in India is of a union budget that came into place. India has been a very, very low spender in public health. It spends about 1.6% of its GDP. The rest is spent on defense, on infrastructure, and a range of things. So suddenly this time for the budget of 2020-2021, there's been an increase in public health spending. But again, because of this view of the pandemic as a kind of crisis, what it's meant is that the additional investment that's been done in public health hasn't been to programs relating to families. It hasn't been relating to giving a minimum wage to health workers. It hasn't been oriented to providing health insurance for the most vulnerable. Instead, what the focus has really been, when we think of it as being episodic and curable, we're thinking then that the additional funds have really gone to vaccine research. They've gone to the distribution of vaccinations. So what we see is an increase in budgetary allocations. So the budget can't really be the only focus, but frontline workers, vulnerable and dispossessed populations continue to be marginalized and no additional investments have come in. The second point I want to make, and this kind of addresses some of the work that Bob does, is that when we think of India and we think of some of the most dispossessed populations, we're thinking also of a prison population. India really has almost, I think it's number 5, if that's anything to even rate, in terms of the world prison population. The prisons clearly are overcrowded. They're much beyond capacity. So at the time of this COVID pandemic, thinking of it as a temporary crisis, the government really woke up all of a sudden to saying, what are we going to do with the prison population during COVID? And as a result of it, the Supreme Court jumped in and took cognizance, suo motu cognizance of this case of COVID in prisons. And it decided that the prisoners that it would release would be based on the seriousness of the offense rather than the risks that were posed to them due to comorbidities. So it's really the estimation of the risk to society rather than the rights and the risks to the prisoners themselves that were taken into account. And so, it reminds me of the entire notion Foucault puts forward of fragile bodies. So whom do you want to control? And when you think of it simply as being a crisis, often you don't want to think of systemic or structural shifts. And now I want to come to the second point, which is when we're thinking about recovery. When we're thinking about recovery, I think my epidemiologist colleagues will often think of recovery in terms of 2 ways. We're thinking generally of a disease and trying to map its connections. What brings together a pandemic? Is it movement? Is it migration of labor? What kinds of mobility? And then there is tracing the genealogy. When you think of recovery, you're also trying to say, how can we recover? But let's quickly also trace the story of where the pathogen came from. What is the genealogy? Where was patient 0? What were the ways in which super spreader events occur? But I feel that in societies with very deep health and social disparities, we really have to think of what is chronic, that the process of recovery itself is not really just a question of policymakers shifting budgets and allocations, but it needs to be diffuse and at very different scales. So what I'm suggesting really to the panel is we think beyond crisis and recovery, think of more emancipating kind of vocabularies when we're looking beyond cures and recovery. We're not looking at infectious disease as just something sudden that we can conquer. And in a way, we need to think of a more empathetic vocabulary. We need to think about this pandemic as being special because of one specific reason. And I want to kind of stress this point for the entire panel, which is that, we've had a range of other pandemics which have been about borders. We've been constantly, when New York was threatened by cholera, people were looking at the borders, were looking at the ports, trying to inspect people. We've been looking externally often at the time of past pandemics. India was constantly policing its borders when it thought the influenza was going to arrive from Hong Kong. But in a way, with the COVID pandemic, it's not the externality that has struck me, but what is internal. So in a way, what this pandemic has really meant is really that the internal has become very important. The internal boundaries of the COVID pandemic are really about who is being policed, what is being rezoned, what is being reinscribed. How are we looking at these large cities where labor has to be disciplined, whether it's cities like Guangzhou, it's cities like Kolkata, it's Dhaka, it's Karachi, all of these places where we see zones of threatening contagion, and it's the internal boundaries that are being disciplined rather than looking outside. So there is, and of course that also means that you look at the virus, not only in terms of its biology, but you're also looking at the social virus. You're looking at immigrants as carriers of the virus. You're looking at Muslims as a source of being of contagion. You're looking at Dalits and lower castes as sources of as sites of intervention, and you're trying to intervene in squatter settlements in global cities. So in that sense, COVID is very different. And now I want to bring in the other point you spoke about, David, which is neoliberalism, which is that, when we've had past crises, let's think of famines, right? We're thinking of, say, the Bengal famine in 1943, which there were more than 2 to 3 million people who died, or famines in China, like in 1959. At that point, what you had was the poorest really did not survive. But what we have with neoliberal capitalism, coupled with biomedicine, is that instead of death, instead of the death of the most vulnerable, what we have is really a sense of exclusion, that there are people who survive the pandemic, but they are really redundant to our economies and societies. Neoliberalism, in a way, will reintegrate, will rehabilitate marginal populations, but it will do that only at their own risks. So even what is offered in terms of employment, whether you work at a warehouse or the new kinds of jobs that have arisen with the pandemic, neoliberalism reintegrates you. It doesn't let you die like in the 40s and 50s, coupled with biomedicine, when you don't see that. But even if, so I'm saying let's not even focus on the number of deaths. Let's look at what really happens in terms of suffering, in terms of the redeployment of people and populations, and how we extract labor from them. The final point I want to make is something I feel has got lost in this discourse. And as someone who works on aging, especially with a focus on New York City, I feel there's a need for us to also ask moral questions, which is not only just the political and the economic in terms of crisis and recovery, but how do we value labor? What's the place, how do we value people's labor? How do we address isolation and loneliness? How can we take certain kinds of connectivity for granted? We count the numbers and the voices of those who are on social media and chatter, but what about those who can't? And in a way, what this crisis needs to bring out to us is that it's important not to recover and to forget. I think the outstanding memory of 1917-18 and the influenza was the fact that it wasn't memorialized. There was really no recollection. And I think we need to see this COVID pandemic as representing a range of multiple crises. And that the recovery is not just a political and economic effort consisting of public health prevention or management strategies, but it's really a way of offering or going beyond the kind of bandage solutions that neoliberalism often offers. What's the kind of thing that the World Bank has always offered the Global South at the time of a crisis? Poverty reduction programs, cash transfer programs, incentives, trying to make peasants and workers entrepreneurial. But all of that really means that the risk falls back on individuals, right? And that's not, we are still setting up structures when individuals are at risk. They're being asked to be entrepreneurial, but we don't have a moral framework where we feel that we want to really change the structures of the system. So in a way, I really feel that the disproportionate burden of COVID and what we talk about needs a sense of a whole moral compass that's also being shifted when we think of crisis and recovery. So I want to kind of emphasize all of this, and I'd like to stop here so that Merlin and Bob can come in and we can also hear the audience. Thanks, David.
Thank you. That was fantastic. Nice framing of the whole panel, I think. Let's move to Merlin, and Merlin will be Merlin Charquanian, who is assistant professor. He's the Gemsen assistant professor of socio-medical sciences at Columbia University. He's the author of many articles. You've probably seen him in, well, you've seen him in many both popular spots like the Washington Post and other broadly read news media, as well as various posts. And he's also been author of a forthcoming book that will appear from North Carolina in the coming months, that will be comparing environmental as well as environmental change and the appearance of disease and crises, political crises in the state and the city. Today he's going to be talking about the United States specifically and the kind of encumbrances that inhibit our reaction and the possibilities of change in a country that has a very specific social history and a very specific political history, and how it affects our response to public health issues in general. Let me just start very quickly, Merlin, by posing a question. Are you optimistic about the future of public health in the United States?
I am optimistic, and I'll address this towards the end, even though what I say is somewhat ambiguous on that. But I am optimistic for a couple of reasons, in spite of what has transpired both in the past year and the past four years. But let me start first by, before I even get to the substance of anything, by thanking some of the folks behind the scenes who put this together. This is a fabulous idea. I wish our city universities collaborated much more, and I hope this is the start of a lot of fruitful events like this. But I want to thank Sam Dijon for helping with the tech, Jessica Coffey, Professor Rosner for putting this panel together, and the Gotham Center and Institute for Public Knowledge for co-sponsoring this. I really admire the public-facing quality of IPK and Gotham Center very much. In my 15 minutes or so on crisis and recovery and public health, I thought I might center to build up to David's question on 4 axes: bureaucracy, economics, epistemology, that is some of what Professor Siva Ramakrishnan discussed, the categories and the ways we frame public health and COVID. So bureaucracy, economics, epistemology, and marginality. And I'll go over all of these 4 axes in order. I'll start first with bureaucracy. I think COVID-19 has thrown into sharp relief one of the chief tensions in public health bureaucracy, and that's federalism. Now, this is, of course, where a centralized federal government must share and constantly renegotiate regulatory power with state and local authorities beneath it. And for the most part, due to precedents bolstered by US Supreme Court decisions like the 1905 Jacobson versus Massachusetts case and others, very broad and autonomous police powers have been granted to states and local governments when it comes to public health. Now, in many ways, this is a great thing. It allows local governments to enact tailored ordinances to very specific contexts that might not be applicable to the entire nation at large. One of the best examples of this comes from my home state of California, where the California Air Resources Board, kind of a state-level EPA, actually continues to pass ordinances that exceed those of the federal EPA. And it's not hard to see why it does this, given the centrality of high automobile traffic in California. But there's also a dark side to federalism as well. Local and state autonomy can swing the other way depending on who happens to head the locality or the state. So in states that are historically prime places for, say, resource extraction, many states have exploited provisions in federal laws that allow them to create their own independent state standards. And in these kinds of states, like Kentucky, for example, you see variances and exceptions where states take refuge in their ability to create much more lax standards. So federalism is very much a structural constraint in public health law and environmental regulation that we've been wrestling with for many decades. It can sometimes be a boon to local and state governments. It can sometimes be a boon to them, but for all the wrong reasons that hinder larger public health causes and imperatives. Now, this internal tension of federalism has reared itself in COVID, especially in the early days. In those early days, American states, as we know, differed markedly in their response to the pandemic, particularly when it came to the imposition of stay-at-home orders and later when to open up economies again. So on one pole were those states that initially were hit the hardest: Washington, Michigan, Connecticut, New Jersey, Pennsylvania, and especially New York, along with California and Massachusetts. These last three states, ones with very robust public health traditions. Their stay-at-home orders and lockdowns were the most stringent, they lasted the longest, and they were implemented the soonest. And on the other end, we had states like Texas, Florida, Iowa, and Georgia. In Georgia, for example, Governor Brian Kemp justified his late April decision to reopen Georgia, even as coronavirus infections and deaths showed no signs of tapering off in both his state and across the entire country. But also, I think states aren't the only story either. There's also a local dimension beneath the federal and beneath the state. This local dimension was also on display in Georgia, where Atlanta Mayor Keisha Lance Bottoms, to take just one instance, publicly repudiated the governor, both by publicly encouraging people to shelter in place and by using executive orders to curtail activity allowed elsewhere in the state. And that kind of local resistance in Georgia may well have actually insulated Georgia from taking a worse turn like that of neighboring Florida, where Governor Ron DeSantis allowed in September of 2020 counties throughout the state to open restaurants and bars to full capacity and has prohibited mandatory mask wearing orders, something that continues into the present there. And meanwhile, in Georgia, back to Georgia, local pressures actually got Governor Kemp to eventually reverse course, at least slightly, when he allowed local mask mandates following months of legal wrangling with a number of local municipalities, most prominently Atlanta. Now in California, on the opposite coast, resistant localities showed that they could also influence state-level actions, but in the other direction. So despite an initially aggressive response by California Governor Gavin Newsom, several localities by May of 2020 became groundswells of protests to public health measures, especially in places like politically conservative Orange County, where a local sheriff's office there said it would refuse to enforce the county's own mask ordinances. And perhaps bowing to this local pressure, Governor Newsom soon allowed restaurants to reopen, and soon afterwards, California diverged from New York as a moderate early success story. So federalism, again, has long been something that has both emboldened but also hamstrung public health. And it can be easy to just view it as this constraint that just sits there neutrally. But federalism is also a contest where various partisans are always jockeying for federalism to work in their favor. So in the case of COVID, fortunately, for now, most local and state ordinances that have been challenged have actually been held up because of those thick precedents in public health law that I mentioned earlier. But there is an ongoing legal movement as well to also curtail federal enforcement power and to devolve as much power to states as possible, including states with much weaker regulations. And most notoriously, this is happening now in a series of legal challenges to the 1984 Supreme Court case, Chevron versus National Resources Defense Council, a landmark case which reaffirmed the EPA's rulemaking power. So whether in a disease control context or public health more broadly, these contests over federalism are something that I think we need to take very seriously, especially in the federal judiciary. My second axis is economics. And here I want to accentuate what Professor Rosner referred to briefly yesterday, and that's Kim Phillips-Fine, one of the panelists yesterday, and her talk yesterday. And she discussed the landscape of scarcity that has impeded social services and governments, including public health departments, since the 1970s. And that's the case not just in New York City, but any large city across the country. Doing far more under far less has become the norm. This is the austerity era. And it's been exacerbated too by three very large tax cuts, first in the Reagan era, then Bush, and more recently, Trump. A lot of local and state effects. And that's to say nothing also about local tax abatements here in New York City that have sacrificed huge amounts of revenue for often dubious projects, Atlantic Yards, Hudson Yards, and from an earlier era, Trump Hotels, many others. I don't think it's hard to see how resource scarcity has hampered COVID control, whether it's having the resources to do careful, systematic enforcement versus the largely voluntary compliance that we have, leveraging novel IT technologies as other countries have for contact tracing or even just effective message dissemination, building an easy to use testing network, and so forth. These are hampered when you have budgetary stress. Nonetheless, I don't think economics actually explains everything. Despite the post-1970s climate, New York City in particular has a fairly robust and innovative public health infrastructure comparatively, and it has endured even when the budgetary axe has wreaked havoc elsewhere. So even after the severe cuts of the 1970s, New York City still boasts, bar none, the most extensive public hospital system in the country, almost a dozen full-service hospitals plus health centers across the 5 boroughs. And this is one of the reasons I believe why New York City, even in the dreary and most dark days of March 2020, did not exceed ICU bed capacity as feared and as happened elsewhere. Moreover, in countries with strong centralized health systems, France, the UK come to mind, other countries in the EU that are generously funded, at least comparatively, have also had a rough COVID experience. And conversely, many low-income countries with strong histories of community-level public health practice, Vietnam, Thailand, and others, have boasted much better results. So I think economics explains many things, maybe even most things, but not all things about this COVID experience. Now, the experience of low-income countries brings me to my third axis, and that's the epistemic, epistemology. That is how people in the United States and the European Union have understood and talked about contagious diseases and epidemics. And it is notable that I'm following Professor Siva Ramakrishnan here, and what I'm about to say in effect amounts to a self-indictment of someone myself who primarily studies the United States. Now, one way people like me, that is an Americanist, one way I teach health is by holding up a graph like this. No PowerPoint, this is all budget tonight. These are downward slopes of infectious diseases over time. I think you can see the downward slopes of infectious diseases over time. And I put up graphs like this, and we call it the epidemiological transition. This is where death rates fell dramatically, and when the classic scourges, diphtheria, tuberculosis, cholera, typhoid, many others, they subsided dramatically, downward slopes. This was due to changes in nutrition, developments in medical care, public health interventions. It kind of depends on who you ask. And anyway, I relate that story and that trend, and then I move on and I tell a general narrative about the transition from infectious disease to chronic disease. And I might issue a couple caveats here and there, namely for HIV/AIDS in the 1980s and 1990s, maybe scattered TB outbreaks or Zika more recently. But for the most part, this is the larger meta-narrative that I go with. That era was over. It was so 19th century. But this is fundamentally an Amerocentric, Eurocentric narrative that ignores that most of the world during the so-called epidemiological transition continued to experience many of the scourges that this narrative consigns to the past. And I think it explains why the notion that a catastrophic, rapidly spreading epidemic could happen here in an OECD economy seems so outlandish and thus made it so hard, even when the first cases of COVID began to surface here, to take aggressive preemptive action. Now, before COVID, a couple decades prior, there were warnings, and those sounding warnings about avian bird flu, MERS, SARS, H1N1, and their potential threat to the United States were often dismissed as eccentrics, and it led to a lot of underpreparation for a crisis of this scale, preparation that has occurred in many of our Latin American, East Asian, and South Asian counterparts around the world, where endemic outbreaks and big epidemics have most certainly not been a thing of the past. On that note, I also hope, back to this broader theme of crisis and recovery, I hope when we do talk about recovery, we rethink the hubris of American and European soft power. There is something deeply contradictory about the fact that much of the global health establishment is headquartered in the United States and the European Union, territories where enormous wealth has been inversely correlated with COVID success. To be sure, global health is a very heterogeneous field with many flavors and different types of people, but much of it retains the West knows best parochialism. So rather than going off to other countries and telling them what to do, I hope to see more deep reflexivity and humility. We need to ask not what, quote unquote, they can learn from us, but what we can learn from them. Last and finally, marginality. COVID is a mirror of larger societal currents, as are many diseases. And if the age of post 9/11 was the age of anti-terrorism and the war on terror, it was also the age of intense nativism, with anxieties about people from the Middle East, Latin America, and Asia rising to disturbing levels. And these anxieties manifest in the form of aggressive raids on immigrant communities, ICE, and so forth, and more recently, extra-legal hate crimes and racially motivated attacks. And COVID is just another data point in a historical rhetoric of blame that has often scapegoated immigrants, racial minorities, and outsiders by tying them to disease. Jews and African Americans and TB, the Chinese and bubonic plague, polio in Italians in the 1910s, Haitians and HIV/AIDS in the 1980s. The rise in recent anti-Asian sentiment, which by one estimation has risen in the past year by 1,900% in terms of racially motivated attacks, is thus anchored in a larger nativist sentiment that has been rising in the past couple decades. So too are the gaping race and class inequalities in who gets COVID and who dies from it. And to close, I want to just accentuate one dimension that I think is missing from the now very familiar, sobering, and depressing statistics on racial disparities in COVID. And that's the interwoven, not separate, but interwoven class character of those racial statistics. This is very much a disease that has obvious universal impacts, but that disproportionately hits those on the lower ends of the economic ladder and in the worst and most vulnerable occupational positions. And we know in New York, occupational position and place on the economic ladder very much bound up with racial position. This was underscored recently by a study published in the journal Nature. The study used cell phone tracking data, remarkable study, by the way, cell phone tracking data to trace the hourly movements of 90 million people, just where they went and where they returned. And it found 3 overwhelming predictive factors for higher probability of COVID from this data. One was socioeconomic disadvantage. The second was regular, repeated movement outside the home. So people who are traveling over and over again, and usually back and forth to the same place. And particularly, number 3, places where the cell phone data showed large numbers of people were congregating in the same space. And so grocery stores and restaurants were implicated here among a variety of other establishments where large numbers of people gather. It's not hard to tell who these people were. These are probably service workers who can't shelter in place, like many of us, and it is they who have borne the largest brunt of the COVID burden. And many of their employers coerce employees to return after a small number of sick days, and COVID days expire, and there is often little oversight of having proper ventilation or PPE or other minimal baseline protections. I think this class and labor character is missing from a lot of the COVID inequality discussion, and I don't think it's hard to see why. Just on a more mundane level, it's easy and routine to collect ascriptive demographic data, but it's much less frequent is asking somebody who is being tested for COVID, for example, how much money they make and where they work. That variable needs to be back on the agenda, as does the broader occupational, labor, and class dimension. Labor and occupational health were central to public health's founding in the United States. Go back to Alice Hamilton's studies. And yet it is actually a much more marginal field of study, even at my public health school and many others, where I can count on one hand the number of faculty who list occupational health as their core issue. The Occupational Health and Safety Administration, or OSHA, has long been a very underfunded agency, as are many of its state-level analogs, but there's no time better than now to rethink how we can revive it and our larger commitment to the safety of this country's most vulnerable workers. And with that, I'll stop right here.
Merlin, thank you so much. I was going to wait for the end of all of our presentations before asking any questions, but since you're answering, a question came across that seems very relevant and very directly related to your talk and the issues you were raising. Dr. Charquanian, I'm interested that you mentioned that countries in Southeast Asia had strong community public health programs and have had better results with COVID. I wonder if you could elaborate a little bit on these results and how they are connected to community public health practice. I just want to add a question to that. Are the practices possible in Southeast Asia applicable to the American context?
I'm happy to answer that, but I'm a little mindful of the time situation. So I think it might be better for Bob to go, because I think also all three of us probably have some
questions. Okay. So, yeah. Okay, we'll wait till later. Great, thank you very much. We're next going to hear from Bob Fullilove, who's Associate Dean of Community and Minority Affairs and Professor of Sociomedical Sciences at Columbia's Mailman School of Public Health. Since 2010, he has been teaching public health courses in 6 New York State prisons that are part of the Bard College Prison Initiative, and serves as a senior advisor to the Bard Public Prison Initiative's public health programs. We're going to hear from him about New York City specifically and New York State and the reactions of our government to what are sometimes identified in public health policy memos as part of a most vulnerable population. How are we treating them, and how does our treatment of them in some sense reflect the contradictions and tensions in public health as it's practiced in the United States? So I'm going to leave it up to Bob, who will blow us away. Thanks, Bob.
David, thank you very much. And thank you as well to all the organizers for what I have absolutely experienced as a quite fascinating discussion about where we are with this pandemic. I'm very pleased to follow Merlin, because I think some of the key points he raised about social class and race are very much a function of what we're trying to understand here in the city of New York, as well as in the nation, where we try to understand this relationship between who's likely to suffer the damage that has been caused by this pandemic, and what characteristics are we most going to be concerned with as we try to figure out what will we do next? How are we going to control this? Are we clear that more than anything else, class and race in the United States typically means that we're not randomly distributed in the population? In urban areas, it's very clear that segregation by race and class is the order of the day. It's the way in which too many of our cities are organized. It's a way of also understanding that this pandemic has a geography. Now, if I might, I think it's important to point out one of the most important lessons that we learned from epidemiology. Never, under any circumstance, should you leave a reservoir of infection untreated. Why? Because the longer an RNA virus like COVID-19 is present in the population, the greater the likelihood it'll change. It will mutate. It will create variants. And because of the rapid changes we're seeing with variants right now in the world, it becomes clear that in some situations, we may not be able to vaccinate ourselves out of this pandemic. So that means we have to start thinking about other kinds of solutions than the ones that have already been put in place to deal with all the problems that this virus has created. Many of you know that for the most part in the United States, we spend an enormous amount of money on healthcare, 18% of our GDP. But what does it go to create? Well, essentially it creates a system where we're going to leave the issue of your health to you. What we're going to be concerned with is what happens when you become sick. We're fully expecting that at the moment you have an illness, you're going to see a doctor, and if it becomes severe, you're going to go to a hospital. Isn't that the way in which we're currently treating COVID-19? We're not spending money to create the social and environmental conditions that promote health. We're really basically saying, if you come down with this virus, go to the doctor, we'll put you in a hospital, and we'll see what we can do to make sure that you will emerge in good health. All the doctors that work at the Columbia University Irving Medical Center will tell you, this isn't sustainable. The doctors are exhausted. Our healthcare personnel are really wearing out. And the whole notion that the best thing we can do is make sure that you have a bed in a hospital means that at some point in time, this is a strategy that simply is not sustainable. It's not going to work. If there is a geography to this pandemic, maybe what we need to do is think about all the ways in which the geography of segregation in the United States is hugely contributing to much of the problems that are associated with this pandemic. For example, in most poor communities of color in the United States, you're going to see a concentration of a variety of conditions: obesity, diabetes, cardiovascular disease. These are all the comorbid conditions that are essentially making mortality from COVID-19 possible. You don't die from a COVID-19 infection. For the most part, if you're young and you get the infection, as people have noted, you're going to be okay. The older you are, however, the greater the likelihood that you're going to be suffering from one of these chronic disease conditions that COVID-19 is going to advantage, that COVID-19 is going to use. And if we look at the geography of where are you going to find diabetes, where are you going to find people with a high level of problems that are associated with high blood pressure, they're going to be in the poor communities of color where the burden of COVID-19 has been extreme. It's important to understand that this is part of the history of the United States. In the 1930s, when we were suffering an enormous depression, you might recall that part of what we did to try and bring banks back into the picture so that they could invest in our cities, the homeowners' own corporation basically set out a bunch of auditors to look at urban neighborhoods and figure out where can banks make an investment. This is what produced the infamous redlining of American cities. Redlined areas were the ones that had high concentrations of people of color, most notably African Americans. If you were in a community that was near a high concentration of African Americans, that area was likely to be redlined. In New York City, many of the redlined communities of the 1930s are with us today, and those are the places that have high concentrations of poor folk of color who, once again, are suffering from the ravages of COVID-19. But understand that this pattern of segregation and health disparities also has a great deal to do with law enforcement. Poor communities are the ones that are going to have the highest rates of crime. Modern policing basically says, send your police, deploy your police forces in the areas that are going to have the highest rates of crime, and let's make sure that there's a cop there to arrest and incarcerate anybody who's engaged in evildoing. Well, that means that poor communities of color contribute enormously to the jail and prison populations in the United States. What do we know about jails? What do we know about prisons? Roughly of the 17 locations in the United States that have the highest concentration of COVID-19, 16 of those 17 are centers of incarceration. Jails and prisons, but especially prisons, happen to be places where it is almost impossible to engage in the social distancing that we know is so essential to keep people free of the virus. Many people have an image of the prison as being a place where you're in a cell by yourself and where social distancing ought to be relatively easy. The truth of the matter is, most prisons in the United States, most state prisons, are places where people are going to be in dormitories. There is huge overcrowding. social distancing is impossible. And that means that you not only will have high concentrations of COVID-19 amongst the folk who are incarcerated, you'll have high rates of COVID-19 amongst the prison staff. And those are the folk who are going to circulate from one place to another. And through their circulation, after having been exposed to this virus, they will contribute substantially to rates of infection in surrounding communities. Let's also be clear that jails contribute to all of this. Once again, what are we going to see when we look at a jail population in most urban areas? You're going to see a high concentration of people of color, and you're also going to see a population, 800,000 on average in any given week in the United States, where 54% are, after a week or so, going to be circulating out of the jail and into the community. Once again, as Kavita has pointed out, it's mobility, it's circulation that keeps this virus alive in the population. I'm suggesting that one of the major factors driving COVID-19 in the United States is our nation's notion that somehow or other mass incarceration is the answer to many of the problems that we worry about most. Concerned about crime? Well, let's lock them up. But the idea that once you are behind bars, you are somehow out of sight and out of mind simply makes no sense from an epidemiological standpoint. The virus doesn't care. And the fact that in the state of New York in 1992, just to give an example of when this was most present, 75% of the prison population in the 68 prisons in upstate New York came from 7 neighborhoods in New York City. No matter how far away they might be physically, it's probably fair to say that many centers of incarceration, many prisons, are sort of extensions of the communities that have as their most important characteristic the fact that they are part of the circle, part of the mobility, part of the circulation that exists between a facility upstate and what is happening here in New York City. Our inability to deal with this on a variety of levels is hugely problematic. Because we're so aware of the fact that prisons and all congregate settings are places where this epidemiological pool of infection is slowly but surely maintaining itself. David used the term petri dish. It's also the case that this is also where you're likely to see the greatest concentration of variants should we leave that pool of infection untreated. So what's the answer? Well, the obvious answer is we should vaccinate. We should not only vaccinate the persons who are incarcerated, we need to vaccinate the staff. That's good public health sense. But what's actually happening? Well, welcome to the United States, a nation that really hates prisoners. Welcome to the United States, where we don't want to coddle people who are behind bars. So in many states, governors are really constrained to think about this problem in simple terms. If I vaccinate somebody who's incarcerated before I vaccinate somebody, and this is how I think they articulate it, somebody who hasn't committed a crime, from a political standpoint, I'm in trouble. So the governor of New York is one of a bunch of governors who's decided, I will make it a point to assure that prison staff are vaccinated, but I'm not so sure I'm going to do the same thing for the incarcerated persons over whom they basically operate and provide the appropriate levels of surveillance. It is simply not good sense. It simply flies into the face of the fact that if you are an incarcerated person in the United States, you are 4 times more likely to be infected with COVID-19 and twice as likely to die. As long as these kinds of statistics are present, it becomes quite evident that our failure to deal with this population is going to have severe consequences for the health of all of us. Think about it this way too. In the state of New York, there are roughly 38,000 people who are serving time in a prison in this particular state. About 8,000 of those prisoners, roughly 21% of the population, are folk who are over the age of 50. We're already aware of the fact that you're much more likely to be hospitalized and you're much more likely to die if you are someone who is over the age of 50 and has unfortunately come down with this particular viral infection. If you think about the fact that we have many public health personnel, many folk who are really concerned about the life of people who are behind bars, who are urging all the things you might do. isn't it at least reasonable to suppose that if we have people who have been behind bars for more than 15 years, who are now in their 60s and 70s, who are very unlikely to commit a crime if they're home, and who are very likely to be suffering from a variety of health problems that are related to their age, and the fact that they came from communities where health disparities are present, doesn't it make sense to just release these people on parole? What harm will they do? What's the likelihood that somebody in his or her 70s who committed a crime as a teenager is going to, at the age of 75, commit another crime when they're out, especially if they're ill and in the kind of health that means that the likelihood of committing a crime is very small? What public good is served by keeping folk like that locked up? What danger are we keeping the public from experiencing? The idea that keeping them there, making them ill, and maintaining the life of a virus which has already upended so much of life in this country and in the world means that good sense, if not a sense of moral and ethical value, would be that we do something significant to make sure that we preserve the life of folk who are in that situation, and in so doing, improve the health of the public. One worries that this is a highly unpopular position to take. And it is very clear that one of the things that happened within, I think, the last 2 weeks was that a group went to the courts and basically said to the governor of New York, listen, your notion that you can only vaccinate the folk who are the staff of a prison flies in the face of the 14th Amendment. Aren't we clear that equal protection under the law means that you can't arbitrarily, in a setting and in a situation where everybody is at risk, decide that one group is more worthy of vaccination than another? The idea that a crime should somehow disqualify you from being vaccinated at some level makes no sense. It makes no sense, especially because if you are doing time in a prison because you stuck up a grocery store or because you stole a car, the jury made it clear that what they wanted you to do was to spend some time behind bars. They did not sentence you to death. But keeping somebody in a setting where the virus is flourishing, making sure that they don't have access to the one factor that might really serve the purpose of preserving their health by providing them with vaccination. The fact that we're unable to do that means that we are being foolish in ways that are difficult to understand. It's a way of saying that our political values, our political notions about who is worthy and who is not, are going to fly in the face of what is clear public health logic. You don't leave a pool of infection untreated. And because we have the means, because we have the capacity, because even the law will allow the governor to make sure that where it's possible, parole can be granted if it will promote the health of the individual and promote the health of the community in general, our failure to do that is something that deserves questioning. I want to believe that part of what is happening with COVID-19 is that we are starting to finally understand what are the consequences of segregation in the United States. If it were the case that COVID-19 stayed in poor communities of color, if it stayed in the jails, if it stayed in the prisons, and we didn't have to worry about it, one could understand why indifference, at least for some groups, makes a lot of sense. It's not my problem. Why should I worry about it? But it is our problem because these pools of infection ultimately threaten us all. Look at the number of leaders of state. Look at the number of folk who become infected just because this virus is that powerful. The idea that we are not doing what we can or should, the idea that good common public health sense is being abandoned because we have a set of values that we think of as being more important than our own health and safety is something that I think at the moment, as a nation, we're ready to question. The most important result of COVID-19 might be that we decide that maybe what we need to do as a nation is invest in the conditions that promote health and prevent disease. That means that we would severely rethink the notion and the wisdom of mass incarceration. We are 5% of the world's population, but we incarcerate 25% of the world's prisoners. Is that serving us at the moment that a pandemic is raging? I would think not. If we're very clear that part of what has made this pandemic so deadly is the existence of otherwise preventable chronic diseases, Doesn't it seem that if we invest in clearing up health disparities in segregated communities, that we'd not only be saving the lives of the people who live in these settings, we'd also be doing a really important thing to save the health of all of us? There's a certain logic that is present as we understand what we need to do to control this pandemic. Whether that logic will win out so that we do the right thing instead of doing what has been politically popular is something that I think historians are going to be asking about in future eras. They'll wonder, what were they thinking? Why didn't they do what was so clearly in their best interest? I think the whole notion that we are looking at the judgment of history as we work through present day realities is something that in a setting like this and in a colloquium like this means that all of us have to be asking the question, what should the next move be for all of us? How should what we decide to do impact the decisions that our leaders make? I believe that more than anything else, the more we become concerned about our own self-preservation, the more in the midst of a pandemic, we'll be concerned about the preservation of our neighbors. And if our neighbors are in communities that are hard hit by COVID-19, this is the moment when we could act decisively to do the kinds of things that would, once again, promote health and prevent disease. You can probably tell from the way I speak that I've had a substantial amount of training in the ministry. It's true. I was ordained in the 1970s, and as somebody who was really active in the civil rights movement in the 60s, I'm always reminded at moments like this of the words of a preacher that I heard in Walls, Mississippi, way back in 1964. If not us, who? And if not now, when? Seems to me that's the question that this pandemic is raising for us. And if it's a useful way of thinking about questions that in this colloquium we should be raising with each other, so be it. How about I stop there? Thank you very much.
Thank you. That was fantastic. I mean, 3 wonderful presentations. I'm going to briefly ask a question that was aimed at one of you, but seems to apply to everyone. One question was from one of our viewers. Several panelists have emphasized that communities of color and minority groups and low-income communities have experienced the most severe impact of COVID due to longstanding economic inequities, the distribution of comorbidities, and other factors. Oh, start my video? Whoops, sorry. There you are. Okay, thank you very much. Tells you my facility with the internet. Longstanding economic inequities, the distribution of comorbidities, and other factors. From a public health perspective, what investments, what specific investments, other than perhaps the most obvious related to the specific populations that we see at risk in a prison or in a specific community, what investments in general would you make favoring those communities to address these disparities in general that would in the long run change the structural relationships that have created these populations being continually at greater risk than others? Are there specific investments in public health infrastructure you'd make? Would you address issues like reducing air pollution, but would you also confront the industries that produce that air pollution, and therefore focus on the kind of deep structural issues that are embedded in our communities, in our societies, in our country?
If I can, I'm someone who really believes that if you look at the way we're handling vaccination here in the city of New York, what is it that you discover? You got to be internet savvy. You got to have a smartphone. Well, what about the communities where you're not only talking about a high concentration of health disparities, you're also looking at an aged population that doesn't know how to operate the internet and probably doesn't have a smartphone. These are the folks we most want to vaccinate, but guess what? If you don't have this connection to modern technology, you're in real trouble. I've always said that hospitals might, at a moment like this, invest in limiting the damage that is created by the digital divide. What if we made it clear that if you are lacking the capacity to do telemedicine, if you're lacking the capacity to make an appointment for a vaccine because you don't know how to access the internet connection that's going to make that possible, isn't it in the best interest of hospitals to literally create whatever is necessary to assure that the lack of access to internet, the lack of access to technology doesn't become a factor in, number one, being able to get a vaccination, or two, benefit from all the things that are probably going to be a part of the telehealth revolution, which I know is going to be a major part of our future. That's not a big deal. But if you thought about the hospital savings that would be generated as a result of having folk who are currently at risk suddenly be in better health so that the impact of COVID-19 and other pandemics won't be so deadly, it seems to be that it makes good economic sense. It benefits the health of these communities, and it does give us a way to deal with all the ways in which we're using modern technology to help us manage the conditions that have been created by this pandemic. That's relatively simple. And because it's doable, it's one of the things that I'm hoping will actually be seriously considered by people in the hospital sector of New York City, as well as, I think it's probably fair to say, nationwide as well.
Merlin, you want to take a crack at that?
I fully agree. I had the same sort of impressions about the vaccine system. I mean, I'm not in one of those categories yet, but I was kind of curious about the interface, and it's both incredibly cumbersome from just a health literacy standpoint, even for somebody with high health literacy, to say nothing of the digital divide issues. But I thought I might pick up on what Professor Fulilev has said by also addressing at least partially the question about East Asian, South Asian countries' success. This is a perfect example of where a robust community health worker structure would go a long way. So if you don't have a computer, or you don't know how to use the computer, or at least use this particular website, somebody is assigned to you and helps you and walks you through it. We have versions of this, and actually I think New York City is better at this than almost any other city, but we don't really have like a kind of comprehensive national framework for people who are embedded in local neighborhoods, who understand and preferably live in those neighborhoods and serve as liaisons between health serving institutions and residents themselves. There were experiments during the War on Poverty era in the 1960s, where this was used in the United States, but those programs have largely been shrunk, if not eliminated entirely. But one of the reasons why I think you see the success that you did in Asia around COVID is partially because of strong community health worker infrastructure that does everything from health education to telling people how to get a test and navigating them through an often labyrinthine public health bureaucracy that is incredibly imposing. So I think that's to answer a couple of these questions, to pick up on what Professor Fulilev said, the question about where I would invest, and the question of Southeast Asia. I would say kind of this kind of bottom up, a well-paid bottom up infrastructure of people, I think would go a long way.
Yeah, I didn't mean a computer in every home. I think that's precisely the way in which the digital divide gets basically bridged. You have people who make the connection. I'm 77 years old. I think I'm at the limit of what I can do with technology. I'd like some help. And I think the connection that you suggest is exactly the one that I think we're in a unique position to provide. We're the will present to actually make a decision and make a move like that.
We're cutting out a little bit, but can you hear me? Is that us, or is that Bob cut out a little bit? Great. Kavita, do you want to take a crack at that? I'm just wondering whether, if pandemics are not just a passing phase, and if this specific pandemic may be amenable to a specific vaccine, how do we handle this in the larger kind of context of a world in which class and race, the issues you raised, are so fundamental to the spread of disease and to the victimization of specific groups? I'm just wondering whether we ever confront this as an endemic problem that is not just isolated and fixable by specific technologies. I just want to throw that in, the big structural issues in which we all discuss as kind of basic to all issues of public health, which are class and race and the structures of our culture and our society. Kavita, why don't you take it back?
I think, to address what Bob and Merlin were saying, I think the one thing we cannot forget is that, I mean, none of these countries are overall models. So even Asia and Southeast Asia, I mean, it's all a question of citizenship, right? Who is a citizen and who gets access, and that intersects deeply with race and class. If you think of this ideal example of Singapore, which completely flattens the curve, 95% of their COVID cases, and this is to answer what Alex was asking, have been amongst an immigrant population that comes mostly from India and parts, various other parts of the world. And they've been able to do that because there's a degree of coercion. They are able to keep them indoors. They get passes to go a few hours a day outside. There's a way in which their labor, the ability to earn has been curtailed. So I'm thinking that the one thing which this panel didn't talk about, which we do need to talk about, is firstly citizenship. Who is a first-class citizen and who comes later? Even when it comes to access, and I agree with Merlin, that is also about community health workers, but they all are addressed to those who are still recognized and who still have cards and verification. In India, it means a biometric card that allows you to be recognized, in which case people like my parents who are middle class will certainly get a visitor. But I'm kind of moving away from that to ask who don't and who are still outside and excluded. So the question I really want to ask is about the nature of the state. Are we at some point trying to say with COVID that more authoritarian states are doing a better job with COVID than the so-called liberal states, which have their own problems, and as Bob and Merlin's presentation brought out, are equally authoritarian internally? So, what is the difference? And does the structure of coercion, of intervention really matter at all? And that comes back to the moral question I was raising. Is it all right to flatten the curve at any cost? And at the cost of certain bodies and lives. So in the US, of course, we're talking about those who, we're not even talking about flattening the curve. So I'm just thinking to myself, where does this come in terms of the politics of who's, what are the costs, what are the social costs we are willing to pay? And at what cost do we achieve certain public health goals? And I think the means are as important as the ends. And that's really the point I want to make.
Wow. Okay. So we're getting to kind of, really basic issues. I think maybe we're getting towards the end of our time. So I'm going to ask this one last question from one of the viewers. Given everything that has been talked about tonight, I'm wondering how each of you feel about what the future holds under the new Biden administration, very practically. Will we see a commitment to broader structural change that addresses inequalities and a shift away from the last 40 years of neoliberalism? Or will we ultimately, as many people have said, get back to normal, which of course, for many people was not such a perfect normal and not such a perfect environment in which so many people lived in poverty and oppression? Who wants to take that on? No one?
I mean, I'll take a tentative stab at it, without promising any predictions, and hopefully also address the very important issue Professor Siva Ramakrishnan raised about citizenship, because I do think the other side of the coin that Professor Fulilove talked about is undocumented citizens in the United States, which are also a central fallout marginalized population to American state coercion, and also deeply contradictory in that this country, to cycle it back to the theme of labor that was discussed, deeply contradictory in that this country depends on undocumented labor, but denies them access to all sorts of social goods, including things like COVID tests and COVID vaccines. But with regard to the Biden administration, so I was on a panel a week ago at the social work school, and it was doom and gloom, and I was surprised at the tenor of it. The doom and gloom was understandable. It came out of the January 6th, coup essentially, and the fallout from that. And one of the panelists focused very heavily on that, and so that kind of that was sort of the tone that was set for the rest rest of the panel. And I had no qualms. I think, at first I thought this was just kind of a bizarre internet thing. And then as you actually read into the profiles of the people who attended this, who participated in this event, it's deeply disturbing, and it does reveal a certain undercurrent that we're going to have to live with. So I didn't dismiss it at all, but I didn't want to leave the audience with a feeling that, it's all, fatally. Lapsing into fatalism and doom and gloom can be just as paralyzing as actually being defeated. So with regard to the Biden administration, I will say there is a couple positive signals that I've seen. One is actually kind of jaw-dropping to me when you compare it to the situation just 10 years ago, which are two people on his Council of Economic Advisors, Heather Boushey and Jared Bernstein. These are two left-wing economists and are very unabashed about it. And the reason why I say jaw-dropping is look at the contrast. Who was there in that same position during the Obama years? Larry Summers, right? So something's going on. President Biden has also signaled some seriousness, I think, in increasing labor protections and easing workers' right to unionize. He's waffled on many things too. His record on mass incarceration during his congressional career is something that I think many of us reckoned with during the election season. But I do think that the social movement energy that we've seen in the past decade or so has definitely exerted an influence on Biden in some ways, and that to me is something to be optimistic about. The question is that social movement energy going to be kind of a flash in the pan or something that sustains itself? And that, I think, is what ultimately dictates the trajectory of the Biden administration.
I really want to.
I'm almost scared to go on because you guys got to be a little upbeat, okay, folks? Okay, Merlin was great ending, but continue, Bob. Go. Don't be too pessimistic.
As well. I came out of the student movement in the 1960s. I spent a substantial amount of time in Mississippi when, at a moment, college students were really saying, "Is this the America that we want to have as part of our future?" Whatever may have happened to baby boomers and what have you, I'm really encouraged by the level of political organization and community organizing that I'm seeing at this point in our history. And a lot of that has literally been created by the hardships of this pandemic. I want to really believe that if we are dealing with a virus that will be endemic, where we're constantly going to have to be changing a whole host of things about where we live and how we live, I'm very encouraged by the energy of young people, because I believe that since it's their future, they really come to understand that whatever happens is at least in part going to be a function of what it is that they do. I think the idea that you just want to sit back and accept what society and the economy gives you, I think that's out the window. And I see more and more young people saying, if things are going to change, it's got to be because we're the ones who are the change agents. As long as you have that kind of energy, and as long as I believe it will be sustained, just because I think this virus isn't going away, I want to believe that optimism is okay. And I myself think about all the things that I'm hearing from my students, both those of whom who are in prison, as well as those of whom who are out. I really do see some sense, some energy that we're not going to go back. And if we are in fact committed to moving forward, the energy I'm seeing with these young people leads me to believe that good things ultimately are going to happen.
Great. Kavita.
Yeah, I would second what Bob is saying. I think, as historians, we believe in critical conjunctures, right? Moments of transformative change, moments when forces come together. And I think this is it. But I think also that people, politics is such that memories are very short. And I think movements, once they're mobilized, I'm thinking of a range of movements in India that mobilized social movements that get set aside. And COVID acts both as an accelerator, but it's also been something that's distanced people, that stopped us from meeting and mobilizing. So it kind of works both ways. But I do think this moment is something that we will not go back on. So I think that is the optimistic part of it. And certainly I think there's such a difference in, I think just listening to our students in the midst of this pandemic makes you feel that we have something which is very secure, and we have a critical mass that actually offers a critique of what's going on. So they don't take anything for granted. And I think that's I feel privileged to be in this moment in that sense.
I mean, a lot of the things that we've discussed about racial inequality, mass incarceration, citizenship, broader economic inequality, labor, to me, as somebody who graduated from college during the George W. Bush years, and then lived through the Obama years, and then the Trump years, it's gone from the edge of the table to the center of the table. Now, discourse isn't everything, but you need to transform the discourse to start the policy change. So I don't think it's a small thing.
Folks, this was fantastic. I love the ending. I'm going to stop it here before we get depressed about anything else. This was a wonderful panel. I specifically want to thank NYU and the City University for helping us organize this. Especially my heart goes out to the City University, which I was a member of its faculty for 20 years and graduated from as undergraduate. So thank you, all you people down at the Gotham Center and at the Graduate Center. Bless you all. Thanks very much. See you tomorrow.